hypothyroidism is one of the commonest causes, commonest endocrine conditions that we have and that you will see in general practice. Overt hypothyroidism is associated with a low T4 and elevated TSH. Very occasionally, secondary hypothyroidism occurs where the T4 is low and the TSH is normal, but that's a very unusual sort of condition. Mostly, the overt hypothyroidism is associated with quite an elevated TSH and low T4. Then there is a large group of patients who fall into that middle range where the TSH is above normal, not above 10, and the T4 is retained in the normal range. And that probably occurs in about 5% of people in New Zealand, probably a bit more actually, as the TSH goes up as we get older. Actually, overt hypothyroidism probably only occurs in 1.5 to 2% of people in New Zealand, and women are much more likely to have hypothyroidism, about 8 times more than men. Gosh, there's so many symptoms and they're so non-specific. The commonest symptoms that are characterized as due to hypothyroidism include weight gain, cold intolerance, a sort of mental fogging that can occur, sometimes carpal tunnel syndrome, general lethargy and tiredness, and there are a number of other less specific symptoms even than those. So you can see that the symptoms are sort of common in average day in general practice, and you might see, gosh, all these people need to be screened. So it requires a little bit of discretion in terms of who would be most likely. And I would say that perhaps it would be a good idea to look at patients who have had an autoimmune disorder, perhaps those with a family history, definitely those who have had treatment for their thyroid, like radioactive iodine, and get clues like that. And men, of course, less common than women. So primary hypothyroidism is divided, if you like, into patients who have overt hypothyroidism. And as you can see on the table, that's where the TSH is over 10, usually on 2 occasions, and the T4 is low, less than 10. And then there is a large group of patients who have what's called subclinical hypothyroidism, where the T4 is actually normal, but the TSH is in that 4 to 10 range. And that doesn't matter for an elderly patient, but it is a prompt to check thyroid peroxidase antibodies in a younger person in particular, and might prompt a repeat test and very occasionally earlier treatment with thyroxine therapy. So for primary hypothyroidism, the best test is a TSH. And we don't recommend it on everybody, but what we sometimes do is ask the laboratory to check a T4 and T3 if the TSH is abnormal. But otherwise, a TSH test by itself is perfectly adequate as an initial screening test. Well, our treatment goals are obviously to make the patient euthyroid. That's our first goal, and obviously to alleviate symptoms. And if the patient has a goiter, I think it's reasonably sensible to see if we can reduce the size of the goiter, which sometimes happens with thyroxine therapy. So the key is to normalize, where possible, the TSH levels and to try and achieve euthyroidism. Now, the TSH level should be between 1 and 4 as a target range for most people. There are some exceptions to that, and one of them is thyroid cancer, where we like a lower TSH, and pregnancy, where we like a lower TSH. And perhaps more importantly, elderly, defined as me, perhaps anyone over the age of 70 to 80, really should probably have a higher TSH. I think the normal range changes a little bit as we get older, and so we can Older people tolerate an elevated TSH very well, and probably the target range need not be so strict for patients who are elderly. The important thing is to choose a brand of thyroid hormone that you feel familiar with, and then to start cautiously, depending a little bit on the severity of the hypothyroidism. In a younger person, you can start with a dose anywhere between 50 and 150 micrograms per day, usually somewhere in the middle. For an older person, you might want to start with a much lower dose, and if the older person has any history of heart disease, then gently starting with even 25 microgram increments is a much more sensible thing to do. The drug should be given on an empty stomach, and so about half an hour before breakfast is the commonest time to take this medication. It shouldn't be taken with interfering drugs or substances like iron or calcium carbonate. Some people have lives that don't always allow early morning taking of pills, or they're not particularly good at taking it at that time. So some authorities suggest that taking the tablet at bedtime is another possibility. And studies suggest that there's not a huge difference between those two, as long as you're at least 2 or 3 hours after your evening meal. But most of the time, half an hour before breakfast is a good time to take the medication. So when you start somebody off with thyroxine, the TSH should be measured approximately 4 to 6 weeks after starting. It takes that long for it to stabilise. And so once the TSH is in the range that you think is appropriate for your patient, then ongoing TSH levels need only be taken once or at most twice a year, assuming your patient you think is compliant. If the patient is not adherent to medication, then sometimes doing a TSH a little more often and bringing the patient in and maintaining that sort of motivation is needed. The two commonest causes would be compliance or adherence, or whatever term you use for not taking tablets regularly, and poor absorption. Probably a distant second, actually, in terms of low T4 levels or high TSH levels when the person is saying that they're taking it regularly. Thyroxine's like every other drug. In an asymptomatic person, it's quite common for people to miss doses. So we say that if you've missed your morning dose, then just take it a few hours later. It doesn't matter exactly what time if you're a non-compliant person. If you're a bit obsessive like me, you'd take it at the same time every day. So mostly, as you know, this is a common condition that general practitioners handle extremely well. And I think if your patient is not responding and the symptoms are persistent, then you might consider referral. I quite like to see young patients. I think under the age of 20, it would be sensible to get an endocrine referral. I think patients with a history of thyroid cancer, patients with goiters, particularly with suspicious nodules and hypothyroidism, should be seen. And I think anyone who's having significant symptoms should be also reviewed.